So welcome to this week's Royal College of Pathologists webinar. So for this week, it's another very topical area. It's to do with testing, but specifically the initiatives that have evolved through the epidemic to expand testing outside the NHS. There are several controversial aspects to this. I'm delighted to welcome Rachael Liebmann, who is not only one of the college vice presidents, but is a consultant at the Queen Victoria Hospital, Sussex, but also group medical director for HSL and TDL, who I think are private diagnostic laboratories. So she's absolutely the ideal person to talk about testing outside of the NHS, regulatory and quality assurance issues. So I'll hand over to Rachael, and I'll be back at the end of your talk.
So thank you very much indeed for inviting me. I'm really pleased to be able to speak on one of these wonderful online seminars that the college has been running on Wednesday nights. So I've been asked to talk about testing outside the NHS, the regulatory and the quality assurance issues. So if I'd just start at the very sort of high level about the college to begin with. We know that the college is an international body. 1/5 of its membership is international. It represents all of the devolved administrations. So it might be based in London, but it's not just England. There are 17 different college specialties. We include dental pathologists and veterinary pathologists, and 1/5 of our membership are clinical scientists. So of all of the aspects that the college gets involved with, one of the things that's very close to my heart and one of the jewels in its crown is its public engagement work. And right from the very outset, the college charter has made clear that it's part of the college's job to educate the public on pathology, what it is and what it does. So at the moment, you couldn't imagine that the college could possibly be unhappy because testing and pathology tests are top of the news at the moment. They are the leading item on the 6 o'clock news, the 10 o'clock news, and here's just a small selection of the headlines in various papers around testing. Testing efforts hit another hurdle. Almost 30,000 invalid UK coronavirus tests had to be redone. Spotlight on testing, questions in testing times. Concern over delays and errors at UK drive-in coronavirus test site. Hospital chiefs increasingly frustrated with UK testing failures, and hospital sound alarm over privately run virus test centre at the theme park. And there is a theme to all of these headlines, and it is that they're negative. That this isn't what we would have wanted in a public engagement exercise run by the college. So the public is very definitely engaged. One of the big bugbears for those of us in the profession is that the public and the media and the politicians don't seem to know the difference between a sample and a sampling centre and a test and a testing laboratory. There seems to be complete lack of understanding about those two issues, and that a drive-through centre is a sampling centre, not a testing centre. So private pathology. Traditionally, private practice in this country has been conducted in small pathology labs which are linked to private hospitals, which tend to be small compared to an NHS hospital. In the last couple of decades, there have been a few public-private joint ventures. So these would then be large laboratory networks involving several NHS hospitals and a private provider, getting literally into bed with each other in terms of profit and loss sharing. So the governance around that, in this country, in private practice for pathology, you have self-employed pathologists and privately employed scientists. Whereas in the public-private joint ventures, what you have are NHS-employed pathologists and privately employed scientists. So the one exception to that is the new entrants to the private practice set up in the UK, which are the American hospitals that are currently setting up in London. So the Cleveland Clinic, which is coming first, and then the Mayo Clinic. And the Cleveland Clinic certainly is going to have an employed physician way of doing things. I personally don't know much about that, except that it's going to be a slightly different model to what we're used to in private practice in pathology in the UK. So to get back to what I was asked to talk about, which is the regulations and the quality assurance. The regulators for the NHS, as we know, that's the Care Quality Commission. They regulate our hospitals and inspect them. The General Medical Council, and all doctors have to be registered with the General Medical Council, and the Health and Care Professions Council, who regulate the scientists. So if we delve a little bit further, regulation and accreditation in the NHS involves accreditation to ISO 15189 standards by the United Kingdom Accreditation Service, or UKAS. It involves oversight by the NHS Blood and Transplant Service and SHOT, the Serious Hazards of Transfusion, and also that layer of quality assurance by undertaking external quality assurance in the various testing areas that are part of the scope of practice for accreditation. So if we look at private pathology providers, their regulators, Care Quality Commission, GMC, Health and Care Professions Council, and the other layers of regulation and accreditation, UKAS, NHSBT, SHOT, and EQA, all similar. There's no difference. You can't get a sheet of paper between the regulatory burden of the NHS and the regulatory burden of private pathology. I scratched my head long and hard when writing this talk to think, was there something that applied to one that didn't apply to the other? And what I came up with was the Freedom of Information Act and all those lovely FOI requests that we get into our NHS trusts. They only apply for publicly funded bodies and they don't apply to the private sector. But I couldn't think of anything else around quality. So when we come to the COVID-19 pandemic, this, as we all know, is a new coronavirus which appeared in December last year. Unfortunately for me, it had several virus name changes, and I struggle to remember all of the different virus name changes, but it eventually settled down as SARS-CoV-2, and the disease that it causes, COVID-19. New tests were really rapidly developed to detect the virus, and chief among these so far has been RT-PCR, or reverse transcription polymerase chain reaction. So initially, it seems like it was years ago, but it was actually only a couple of months ago, when Public Health England was no longer performing all of the tests in England, there were capacity issues. The capacity issues fell into these categories, and not everybody was hit with the same of these, but this is the list that I could think of when preparing the talk. So there were a few CE marked assays and testing platforms in the UK. There weren't very many experienced molecular virology scientists. There were few virology laboratories set up to undertake 24/7 working. They tended to work office hours, or perhaps an extended office hour. There was an international shortage of the reaction extraction reagent for especially the closed platforms. And there's an international swab shortage, and that's still the case now. And that's one of the features of a pandemic, is it's not just a shortage in this country, it's a shortage everywhere. So it's dog eat dog for procurement. So in the UK, as a response, I believe, to the problems with capacity, there were restrictions on who could get tested. And that was initially restricted to patients being admitted to hospital with severe pneumonia. So an ordinary symptomatic individual who was not that severely affected that they needed hospital admission were simply advised to stay home, and they weren't offered any testing. And most, but not all, of the private providers in this country kept to those same restrictions. And certainly the private providers that I have connections with kept to the same restrictions, despite some really quite exceptional pressure, as you can imagine, from the rich and famous to make exceptions for them. So as part of the response to the capacity issues, the pop-up or lighthouse laboratories were set up, and these are a partnership. And I've listed there the entities that are in the partnership. And these laboratories are based in Milton Keynes, Alderley Park in Cheshire, and in Glasgow. And slightly later than that, but not much, the Francis Crick Institute in London also set up a testing facility, which is outside of a normal diagnostic laboratory. But what was different about the Francis Crick Institute was they did that in partnership with Health Services Laboratories and with University College London, and they specifically set it up for NHS staff testing. So for the field laboratories or the non-NHS laboratories, the layers of quality assurance that are in place. So UK NEQAS has announced that it's really doing very well at setting up and rolling out the EQA scheme for COVID-19 testing. So we're all familiar with EQA schemes, and it's great to have one for COVID-19. UCAS has been to visit, and I've been told, I noticed that the UCAS assessor that I share with the Lighthouse Laboratories is on this call listening, but I'm told by the Lighthouse Labs that they're visited weekly by UCAS. And I wonder just how many of us would fancy swapping and exchanging places with the Lighthouse Labs for that. And there is a checklist which all of the visitors will go through when they visit the field laboratories or the non-NHS laboratories. So I'm going to run through that checklist very quickly with you so that you can see just what is looked at. So for operational management, they look at the scope, they look at the quality management system, they look at whether there's an operational lead and a clinical lead, they look at staffing numbers and supervision, business continuity, liability and indemnity cover. They look for SOPs and for troubleshooting abilities. They look at what training is provided for staff, and they look at things like competencies and EQA. They're looking for internal quality control and, again, EQA, validation and positive run controls. They're looking at transport arrangements and the follow-up of any samples which weren't received. They're looking for sample reception and specimen handling processes, PPE, date and time sampling, and it goes on and on and on and on and on. So when it comes to reporting the report out, they want to know that there's a registered professional doing the reporting out, that there's a LIMS, a laboratory information management system in use, that there's a process for reporting and what's sent and received, and that there's measurement of the turnaround times. So to imply that the field laboratories or the testing that's taking place outside the NHS is not regulated isn't strictly true. The areas where I think there would still be an argument would be, are they fully accredited with ISO 15189? And the answer to that is no, they're not. But it would be very hard to imagine any laboratory set up only a couple of months ago already having successfully gone through ISO 15189 accreditation. So the other argument is, do they have integrated IT, especially with general practice, with community, with your local directors of public health? And that's really important for the test and trace. And so again, you have to say, while the IT that was mentioned in the checklist was all laboratory, internal, is there integration with those external bodies? And the answer to that for the Lighthouse Laboratories is no. The answer to that currently for the Francis Crick Institute is yes. And that's because the Francis Crick Institute is partnered with the diagnostic laboratory. So the other questions that I have around the future for these field laboratories is, what might their role be in serology? And what role, if any, do we think they may have for the future? And on the screen, you'll see an advert that was recently placed on the Amazon website for a laboratory manager to be employed by Amazon because they would like to increase their testing capacity. And as far as I'm aware, Amazon is not listed on the CQC website as a pathology provider, and certainly does not have ISO 15189 accreditation. So I think we're not done with new entrants to the marketplace just yet. So I wanted to talk you through what we've done in Brent and Harrow. So Brent and Harrow CCG wanted to set up community testing. And it won't be a surprise to anyone listening to this that the care home staff and residents are a big issue with regard to COVID-19. So what we set up in that part of the world is electronic ordering for these tests at the hub via ICE. We set up full collaborative IT support. We set up 2 courier collections in every operational day to transfer the specimens. We guaranteed a 36-hour turnaround time for all requests. The reporting follows these steps for full governance and full traceability. Via pathlinks back to the requesting hub as temporary registered patients. On ICE, where the reports are assessed by the respective clinicians. Via pathlinks to other GPs in Brent and Harrow, according to what was said about copy GP in the request. And if any of the staff and patients are from outside Brent and Harrow CCG, we provide paper copies of the results to those GPs. And of course, we send a text message, an SMS message to the patients and the key workers themselves who have been tested. So I think that's pretty damn good. It was achieved within a week of a formal request and within 2 weeks of the initial verbal inquiries as to could we set this up. It's perfectly functional, it's all working extremely well. And so it wasn't a huge surprise to us that an adjacent CCG was also interested. And so we started to have conversations with them and are still having conversations with them. But what they then wanted to know when we described what we put in place and what was needed was, why can't it be like IKEA? And so we still have a huge education piece to do with the public, with the media, and even with our commissioners, the CCGs, about what's wrong with just rocking up to a car park and having a sample taken and not having any of these IT links and processes in place. So thank you very much for that. And I'm happy to take any questions.
Was it a good idea for the government or whoever it was that set up the Lighthouse Labs ahead of or instead of using NHS and existing private diagnostic labs to full capacity and taking advantage of expertise in university labs?
So I don't know who made that decision. I certainly am not aware that the college had any input to that decision making, and that's been a source of frustration for the college, the level of consultation around that kind of decision. I would have preferred that the existing accredited capacity had been maxed out before going out to new entrants. And especially since reagents are in short supply, swabs are in short supply, it would seem to me to make more sense to use the people that you know are already in the system. And then, of course, your IT connectivity would also have been in the system.
Okay, and it's very difficult for those of us not involved with the Lighthouse Labs to know how they're doing. So I certainly read articles about people who volunteered to go and work in them, expecting to work 12-hour shifts, turning around thousands of samples, having to go home at lunchtime because there was nothing to do. Is that still the case, or are they functioning properly?
So I don't have an inside information as to the number of cases that they're doing. My understanding is that, like the rest of us, they are not working to capacity. And I think that's partly because we restricted who could get a test. If we'd been testing everyone who had symptoms at the height of the pandemic in the UK, I think we'd all have been working those 12-hour shifts. But that did not ever happen. And still, it's not available to that extent. And even the new test and trace, which has been announced, the testing is for the initial index person who has symptoms, but the contacts that they name are not going to be offered testing.
Okay. Okay, this reflects my own background, but how on earth did we let the terminology become antigen testing? We haven't done antigen testing for donkey's years, and yet this is the accepted terminology. Was it not the college role to educate the the politicians as to what we actually do?
So I actually think that the phrase antigen testing didn't arise from the politicians. I think even the word antigen's a little advanced for most of the politicians involved in this. Most do not have scientific backgrounds or degrees. So I think antigen testing came from our clinical colleagues who are not pathologists. And yes, it is our job to educate them. And I'm happy to send out a challenge if you can find a college document that uses the phrase antigen testing for when we mean RT-PCR. I'm very happy to take that on and change it.
Okay, I'm going to read this question out verbatim. So a friend in London had a private COVID-19 antibody test and asked me about the result. I noticed the lab's medical director was a GP, not an RCPath. And while the lab was recognised by the CQC, there was no evidence of UCAS ISO accreditation. How is that lab able to operate?
I can give you the very short answer. I don't know. I have noticed, again, newspaper articles, media articles, that there are these incredibly entrepreneurial groups of medics, and they are medics. And they are GMC registered. And so therefore there is a risk to them for undertaking things that are outside of their expertise. But they have set up testing laboratories in all sorts of places. I've also heard of people being given quite unusual, shall we say, interpretations of the test results and given clinical advice that would not fit with the national guidelines based on the results of these tests.
So in the list of things that UCAS inspect, you did mention that a registered professional should report out the results.
Yeah.
What is meant by that phrase? Do you have to have expertise in pathology, FRCPath?
So I don't know. I would hope so. And I would hope that UCAS would make that kind of representation, that if they're being reported out by somebody who's a registered doctor or scientist, but doesn't have FRCPath, that would be looked at. But you have to remember that not all pathology tests are reported out by the medics, that a lot are auto-authorized or reported out by our scientists. So again, it's a very, very good question, and one I don't know the answer to, but I would certainly expect that there was oversight from an FRCPath qualified registered professional, but I can't tell you whether or not that's in place. I can tell you for the Francis Crick Institute that it is in place, that all of those results have a registered scientist or a medic involved in them.
So the Crick Institute is a fantastic example of how things should be done. I absolutely agree with that. I have a question here saying, given the numbers of world-renowned universities nationwide, why do we only have one collaboration between HSL and Crick? Mid-March, there was an audit of all the PCR and qPCR equipment at our university, and so far I haven't heard any testing at our university.
So my understanding is that there was that audit done, and then not all of it was followed up. And I wonder, was that because they realized the capacity wasn't needed in addition to the Lighthouse laboratories? But my understanding is that there is still an ongoing look for surge capacity, because we're not sure that we're seeing the end of this virus. There could be a second wave or a third, or it could become endemic. And so we may need surge capacity. And so my understanding is that at least some of the universities are having ongoing discussions with government. But you would need to ask government, or in England, Public Health England, what happened to those initial requests that the universities had, and where the decision making was around that. It certainly, again, was not something that the college was consulted on.
Okay, I could add to that I think there is testing between Birmingham University and the Birmingham PHL collaborating. And I know from my own university that our university lab is working in partnership in terms of innovating the assays without actually processing diagnostic tests. So there are examples outside, but clearly the Crick is the best one, and the one that we should aspire to. So what about notification of infectious diseases? Are all these diagnostic labs appropriately notifying?
So again, I can tell you what my understanding is. and I can tell you what's happening at the diagnostic laboratories I have a handle on, and the Francis Crick Institute. So my understanding is that a list of all of the positive patients is provided by the Lighthouse Laboratories to their respective public health. So in Glasgow it will be Public Health Scotland, and in the other two laboratories it will go to Public Health England. But that is, my understanding is it's like an Excel spreadsheet, a list of names. And so someone has to do the data transfer for that, for any meaningful additional investigation to be done. And it certainly doesn't link to the local GP, to the care home, patient records, anything like that. It's very separate. The Crick is managed in the same way as Harrow CCG that I mentioned. So again, those are all notified. They're coded and they're notified in the appropriate way as if they were NHS samples.
Okay, I'm learning things here. So somebody's texted in that the Premier League has paid £4 million to a private COVID antigen testing provider who claims TDL are providing the test. This equates to 16,000 tests per month. Is this a justifiable use of the limited testing resources?
Okay, so it's not antigen testing. And the contract size that's been quoted, that has actually got a middleman, an organization called Prenetics, and they hold that contract. But yes, the laboratories they're using are TDL laboratories, and the go-ahead for that was at governmental level.
Okay. Couple of comments about the Lighthouse Labs. Is UCAS giving the Lighthouse Labs priority in terms of their inspections? Because there are people whose UCAS inspections are being postponed with no date rearranged, and yet obviously UCAS are going out weekly to these Lighthouse Labs.
So that's an interesting one. My understanding is that UCAS were prepared to do accreditations at a distance unless the laboratory themselves asked for a deferral. So I don't think those deferrals are from UCAS's point of view. I think those are deferrals that the laboratories asked for.
And is it right and proper that a Lighthouse lab should have been reporting diagnostic test results without UCAS accreditation and in such a very short period of time? Again,
that was a decision taken way above my salary level. That was a governmental decision.
Okay. If there is now spare capacity, and I think we'd all accept that there is, then why are we not testing the contacts in the contact tracing?
Again, I don't know. I would have thought testing the contacts would be quite sensible. But again, that's not been offered. The one thing that is still in relatively short supply is the swabs, the initial swabs. And so I wonder if the maths has been done on that and there's still some sort of a restriction.
Okay, if I can move away from the RT-PCR to the antibody testing, again, something which many people feel strongly about. It seems to have been rolled out in a rather uncontrolled fashion, and despite the college advising that we should only do pathology tests that influence patient management and we shouldn't be doing unnecessary tests, we're being asked to do thousands, literally thousands of tests for which it is explicitly stated the results have no clinical relevance.
Yep.
Is this an appropriate use of resources?
So I think there are two reasons for doing antibody tests. One is a very human one. Everybody wants to know if they've had it. And so I can give you an example of an organization that offered it to its staff as a perk, just a staff perk. You can have antibody tests. This is an organization outside of the UK. And they thought they were going to have about 50% of the staff take it up. And so they modeled for 50%. 100% of the staff took it up. So this is not a UK organization, but that's the level of interest. People want to know. But the other reason for doing it is to look at your population. And it's that epidemiology approach to who has had it, where has it gone, and also what is our immune response to it, which we really do need to study. We need to know that, and we need to know it at a large scale. So again, the decisions about the numerical numbers of tests to be achieved, the date at which that was to start was brought forward by several days, which again made life very, very difficult for those of us that were involved in doing this. But yeah, rolling out antibody testing has been the fastest thing I could possibly have imagined. And yet they all go out with that caveat on the report that this shouldn't change your behavior. Yeah.
Okay, I mean, it's a political question, so it's unfair to put you on the spot, but there's no doubt we need the epidemiological data, but if you want epidemiological data, you should do an epidemiological study, and you should sample according to the correct strata, the correct geography, the correct ethnicity, the correct age groups and gender, and so on. But I must announce, if people aren't already aware, that the Royal College has released today a strategy document for testing, and the very first part of that document outlines the 7 principles behind doing a diagnostic test, and I very much welcome that. And I've had a question on, do you feel that that strategy document will now ensure good use of testing resources and standards?
I can only hope.
Right, okay. So there are 1 or 2 off-the-wall questions here. There's one about testing sewage, which I'm going to try and find. I lost it. Okay, we'll talk about false positives and negatives. So yes, certainly the PCR tests have a false negative rate, which is somewhat alarmingly high, anything up to 30%, maybe 10 to 30%. Is this a sampling issue or a quality issue? Is it being investigated? How can it be improved?
So not all assays are the same. And even when you take the same assay and you do it in different laboratories, you will get different results. And that is why we do a laboratory verification for everything new that we start doing. I mean, that's because it varies. So I don't think you should assume that there's a 30% false negative rate for any test anywhere in the country. I think you should assume that there's a range. And certainly at the beginning of the epidemic, especially when extraction reagent was in very short supply, the sensitivity was very good, but we couldn't apply it to very many cases. I'm really proud to say that it was HSL scientists who helped to devise one of the extraction-free methods, and that reduced the sensitivity of that assay a bit, but not so much that it was down towards the lower end of what some laboratories were declaring as their sensitivities. And so it was still possible to go ahead without extraction reagent. So this is complicated stuff. But yes, there's definitely a sampling issue. And initially I had assumed, and I know that there were statements on websites to say that all of the drive-in centres would be a medically qualified, well, a clinical member of staff would take the sample, and that's not what happens. What happens in most of the drive-in centres is that it's a self-sample, and in theory it's under the supervision of someone who's been trained, but in practice in quite a few of the drive-in centres, I'm told, I haven't used one, you're told to go and park your car in another part of the car park, and no one is actually looking through the windows to see if you're taking the sample correctly. So I'm quite sure there's a sampling error issue in that false negative.
It's out of interest. Are you aware of any data that saliva is an equally useful sample or not?
So again, this is not my area of expertise. I'm aware of studies looking at saliva, but I wouldn't wish to opine on whether or not I thought that was as good.
Okay. So I found the sewage question. I've heard that testing viral levels in sewage could be a good indicator of the level of infection in the population. Has this been tried or considered in the UK, publicly or privately? I'm not aware.
So I honestly have. So what I'm aware of is that there is excretion of viral particles in feces, and that can be detected. I had seen again in the media something about sewage testing. I'm not aware of anyone volunteering to test sewage. But again, if you were looking at a whole population, I think that's a reasonable suggestion that you might know from the sewage what level of infection there was in the population. Again, I don't know what you would take as your control. Maybe sewage in New Zealand could be used as the control.
So there's a research project for somebody to write up there. I've had a message that the statement about UCAS visits being postponed and Lighthouse Labs getting priority is incorrect. I'm happy to correct that.
Yeah.
Okay. And I'm also getting a message that we need to wrap up fairly soon. Yes, someone raises the issue of the fact that there's a whole variety of antibody tests. Have your labs taken on antibody testing?
Oh, yes. Yeah.
Are you using just one commercial kit, or are you using more than one?
Again, given the issues with the supply chain, we're using more than one commercial kit. I think it's a leap of faith to only put all of your faith in one kit, and for the supply chain to keep you supplied whenever you've made promises to people who need those tests.
Okay, yeah, we had a talk from Richard Tedder very early on in this series, who did say that he felt a full understanding of what antibody results mean does require doing more than one antibody test, whether it's anti-spike and anti-nuclear protein or neutralizing antibody, but a single assay and a single test may not be as useful. Okay. Do you have any experience, or are you accepting capillary blood samples or dried blood spots as opposed to venous bloods for your antibody test?
We're certainly looking into it. I think that's a very useful test for people who can't access phlebotomy, either because there aren't sufficient phlebotomists in their area, or because they're shielding and it wouldn't be clever for them to go out to get this blood test. So yes, I think capillary blood would be very useful. We tend not to use blood spots, but I know that there are quite a few laboratories, large, well-known laboratories, who have excellent results with those for other analytes, and I don't see why they wouldn't have them for COVID-19. We tend not to use them, but we do use capillary blood for quite a few things, and yes, we're looking into using it for COVID-19 antibody testing. Okay,
I'll make this the last question, and you did refer to it in your talk, but perhaps you could expand on it. What is the future of the Lighthouse Labs going forwards?
So again, I probably best refer you to the college testing strategy, where it says that the expectation is that the Lighthouse Labs will be wound down.
Okay, right. Well, I think I've covered there's a lot of questions. It's very difficult for me to keep up with them all, but I hope that I've passed everyone's on. I think I have. In which case, it just remains for me to thank you. It's been a very enlightening talk. We strayed off the strictly regulatory and QA issues into other areas, but I think that was inevitable. It's clearly a hot topic as to how these testing policies are being evolved and implemented. I would hope that the college has a major part to play in trying to direct policy down appropriate avenues, which I feel personally we haven't always been doing thus far. But clearly it's a complex situation, it's evolving rapidly, but it's been very interesting to hear your views and have your expertise. So thank you very much indeed.